Good day, everyone. My topic for today is good operating room practice, preventing harm. I'm Dr. Matalata and the chairperson is Dr. Bana. Table of contents. We'll go through introduction, preventative strategies on errors, distractions and disruptions, WHO checklist, infection prevention, COVID theater, temperature control, and closure will have references. Introduction. Healthcare providers' competency in the operating room is a key component of patient safety. Various factors may compromise the performance of healthcare providers in the operating room, including stress, sleep deprivation, and noise. Patient safety in the operating room has improved in the last decades, but significant risks remain. Adverse events may be subtle and delayed, or dramatic and immediate. Human errors and communication failures contribute to most adverse events. Surgical site is an important cause of morbidity and mortality. A well-designed system must be in place to prevent and detect errors as well as reduce harm when a mistake occurs. A useful tool to promote patient safety in the surgical setting is the surgical safety checklist published by the WHO. Human errors, types, and prevention. The science of safety is based on the premise that everyone makes mistakes and that specific processes can be implemented to prevent mistakes or minimize their adverse impact. Individual errors or unsafe acts may occur when a technique or a recommended process is unfamiliar, when a clinician believes that the unsafe act increases productivity or convenience, e.g., by not performing hand hygiene, or when poor communication results in unintended act. Action-based errors. Action-based errors, such as placing a needle in the carotid artery instead of the internal jugular vein, or intubating the esophagus instead of the trachea, are relatively common, but are usually identified and easily corrected. Prevention of action-based errors includes implementing known safety precautions, such as use of ultrasound guidance for central line placement, standardizing techniques so that deviation from the expected result is more easily recognized, building redundancy into systems, such as two-person checks, use of both ultrasound guidance and transduction of a waveform from 18 needle or catheter that is inserted into a central vein prior insertion of a larger 8.5 Renet introducer shape. Decision-based errors. Decision-based errors due to faulty knowledge or judgment are more insidious and difficult to identify and correct than action-based errors. Critical thinking failure and cognitive biases may lead to inadequate risk assessment, incorrect diagnosis, and/or incorrect choices of treatment, and such errors may be compounded by persistence on an incorrect path. Prevention of decision-based errors involves strategies to improve awareness and insight into cognitive biases and increase consideration of alternative possibilities. Interventions include cognitive aids to decrease reliance on memory-true algorithms and computerized decision support. Such aids may be particularly important during emergencies. Simulation training to develop cognitive walkthrough strategies for specific clinical scenarios. Implementation of evidence-based clinical practice guidelines. Communication-based errors. Communication failures occur commonly in the operating room setting and are the leading root cause of serious adverse events that result in patient harm. In one study, nearly 1/3 of all operating communication resulted in partial failure, such as poor timing, missing or inaccurate content, wrong audience, ineffective communication resulting in failure to resolve the issue. Safety interventions implemented in the OR and the other hospital settings that are designed to improve communication include employment of a pre-operative briefing to ensure thorough communication among all members of the team before an intervention begins. Use of structured communication, teamwork training to teach communication skills. Distractions and disruptions. Disruptions occur frequently during surgery. In some cases, there are more than 30 door openings every hour. Conversations, alarms, door openings, and even music can result in disruption of surgical flow, as well as creating excessive noise level that interferes with communication. Distractions and flow disruptions causes technical errors which are associated with adverse events and mortality. Techniques to minimize distractions include limiting the number of extraneous individuals in the operating room, limiting interruptions to the surgeon to those that are critical, e.g., questions about cases for the following day can wait until the end of the surgery, turning all bleepers to vibrate instead of remote, and assigning personnel to manage pages, reducing noise level from all sources. The WHO Surgical Safety Checklist. The checklist is a simple, practical tool that's used to ensure that the pre-operative, intraoperative, and post-operative steps are undertaken in an efficient and timely manner to benefit the patients. The aim of the checklist is to reinforce accepted safety practices and foster communication and teamwork. It reduces patient morbidity and mortality, as well operating theater time. There are 3 phases of the checklist, such as sign in, time out, and sign out. Before induction of anesthesia, the sign in phase includes the patient has confirmed her identity, the surgical site, the procedure, and given consent. The site might be marked, some cases might not be applicable. Anesthesia safety check completed. Pulse oximeter on patient has been placed and functioning. Assess for allergies, difficult airway and aspiration risk, and also risk of blood loss more than 500 mL. Before skin incision, there's a timeout phase. Confirm all team members have introduced themselves by name and role. Surgeon, anesthetist, and nurse verbally confirm patient, site, and procedure. Anticipated critical events. Surgeon reviews. What are the critical or unexpected steps? Operative duration. Anticipated blood loss. Anesthetic reviews. Are there any specific patient concerns? Nursing team reviews. Has sterility been confirmed? Are there equipment issues or any concerns? Has antibiotic prophylaxis been given within the last 60 minutes? Is essential imaging displayed? Before patient leaves operating room, there's a sign-out phase. The nurse verbally confirms with the team the name of the procedure recorded, that the instrument, sponge, and needle counts are correct, how the specimen is labeled, whether there are any equipment problems to be addressed. The surgeon, the anesthetist, and nurse review the key concerns for recovery and management of this patient. Comparisons of recommendations for preventing surgical site infections between guidelines. Recommendation: parenteral antibiotics. The NICE, they recommend single dose of antibiotic prophylaxis intravenously on starting anesthesia. The ACOG, they recommend single dose antimicrobial prophylaxis, additional intraoperative doses for lengthy procedures or excessive blood loss. The ACAS and SIS, they recommend single dose within 60 minutes of incision and redose based on half-life of antibiotic and blood loss. The WHO recommends single dose within 120 minutes of incision, taking half-life of antibiotic into consideration. MRSA screening or carriers prophylaxis. Consider nasal mupirocin in combination with a chlorhexidine body wash before procedures with Staph aureus is likely to be a cause of a surgical site infection. That's from NICE. The ACOG, for patients with a history of known MRSA colonization who are undergoing surgery through a skin incision, use the recommended MRSA antibiotic prophylactic protocol or adjustment of the pre-operative prophylactic antibiotic regimen to include a single pre-operative dose of vancomycin. Screen and decolonize cardiac and orthopedic patients with Staph aureus. That's from the ACS and SIS. WHO, nasal carriers of Staph aureus undergoing cardiothoracic or orthopedic surgery should be decolonized with mupirocin 2% ointment prior to surgery. Consider treatment for known carriers for other types of surgery. Skin preparation of the surgical site. The NICE recommends use alcohol-based solution of chlorhexidine or aqueous solution of chlorhexidine if operating next to mucous membrane. Alcohol-based solution of povidone iodine if chlorhexidine is contraindicated, or aqueous solution of povidone iodine if alcohol-based solution and chlorhexidine are contraindicated. The ACOG recommends use alcohol-based agent unless contraindicated. Chlorhexidine alcohol is an appropriate choice. The ACAS and the SIS, they recommend use alcohol-based preparation unless contraindicated. WHO recommend use chlorhexidine alcohol-based antiseptic solution unless contraindicated. Pre-operative skin wash. NICE recommends shower or bath using soap either on the day before or on the day of surgery. The ACOG recommends advise patient to shower or bath full body with soap, antimicrobial or non-antimicrobial or antiseptic agent on least the night before abdominal surgery. The ACAS and the SIS, they advise patient to shower to bath prior to surgery with plain soap or an antimicrobial soap. The WHO recommends ensure patient showers or baths before surgery using either plain soap or antimicrobial soap. Patient homeostasis. The NICE recommends to maintain temperature in line with NICE 2008 guidelines. Maintain optimal oxygenation during surgery. In particular, give patients sufficient oxygen during major surgery and in the recovery period to ensure maintenance of a hemoglobin saturation of more than 95%. The ACOG recommends implement pre-operative glycemic control and use blood glucose target of 11 millimoles in patients with and without diabetes. The ACS and SIS recommends aim for target blood sugar of 6.1 to 8.8 millimoles per liter. Pre-operative and intraoperative warming recommend 80% supplemental oxygen to be given before operation, that is under general anesthesia. The WHO, they recommend use protocol for patients with and without diabetes before surgery. Warm patient during surgery. Use 80% fraction of inspired oxygen intraoperatively and 2 to 6 hours post-operatively. Still continuing with the recommendations. Vaginal cleansing. The NICE, they don't have a recommendation. ACOG recommends with either 4% chlorhexidine gluconate or povidone iodine before hysterectomy or vaginal surgery. And the others, they don't have recommendation. On hair removal, the NICE recommends do not use hair removal routinely. If hair has to be removed, use electric clippers with a single-use head on the day of surgery. Do not use razors. The ACOG, they recommend hair should not be removed routinely unless it will interfere with the operation, in which case it should be done immediately before surgery, preferable with clippers. Do not use razors. The WHO recommends do not shave, but if absolutely necessary, use clippers rather than razors. On skin closure, the NICE consider using sutures rather than staples to close the skin after cesarean section to reduce the risk of superficial wound dehiscence. And the others, they don't have recommendation. Negative pressure wound therapy. The NICE recommends high-risk women for primarily closed surgical incisions, and the WHO recommends in primary closed surgical incision in high-risk women. Continuing with the preventative strategies for infection control. To prevent deaths from sepsis, prophylactic antibiotics must be administered 30 to 60 minutes before surgery. The current practice entails giving 1 gram capsule instead. It is advisable to give higher doses when weight is above 100 kg. For an example, give 2 grams if above 100 kg, 3 grams if above 120 kg. In theater, WHO surgical safety checklists must be used all the time. Prophylactic antibiotics second dose might be considered if the blood loss is more than 1,500 ml. Operation is surpassed in more than 2 hours. If there's a blood loss of more than 1,500 intraoperatively, the second stage emergency Caesar, prolonged rupture of membranes, multiple vaginal examination during labor, and immunocompromised patient, a 3 days course of antibiotic, of ampicillin 2 grams 6 hourly, gentamicin 240 daily, and metronidazole 400 milligrams 8 hours is advisable. Unexperienced surgeons should perform the C-section if there's a BMI of more than 40, previous septic wound, previous C-section 3 times. To prevent accidental bowel or bladder injury, a midline skin incision is recommended if there's 2 or more previous transverse incisions. Aerosol generating procedures like intubation, endoscope, laparoscopy may transmit COVID virus during this pandemic. For suspected or confirmed COVID-19 cases, a pressure-controlled operating room is recommended to prevent viral dissemination beyond the theater. This consists of 4 interconnected rooms, in which 2 anterooms, that is induction in the scrum, with a lower atmospheric pressure than the operating room, are sealed by interlocking doors with airdrop seals. Simulation of procedures improves safety and reliability during high-stress environments, and advanced personal protective equipment and powered air purifying respirators are used. Only the most senior anesthetist and 2 assistant nurses are present during induction. After incubation and extubation, a lockdown period of minimum 5 minutes is allowed for air cleaning, or 15 minutes if laparoscopy was used. Patients recover within contained environments and specific wards according to variant presence or absence. Temperature control. Baseline ambient temperature ranges between 21 degrees Celsius to 26 degrees Celsius. A routine clinical intraoperative standard is to maintain the patient's core body temperature between 36 and 37 degrees Celsius. The operating room temperature is frequently maintained around 23 degrees to prevent hypothermia, which is a common complication of prolonged anesthesia and surgery with an incidence as high as 70%. Hypothermia can occur due to exposure to cold environment, evaporation of skin sterilizing solutions, and the impairment of thermoregulation by various anesthetic agents. Hypothermia is associated with increased intraoperative blood loss, a higher incidence of morbid cardiac events, and an increased risk of surgical site infections. Therefore, maintaining normothermia has become a quality improvement measure in many institutions. Preventative measures include increasing the ambient room temperature, forced air warming systems, heated mattresses, chemical warmers, and the warming of intravenous infusions and fluids. Thank you. And there's my references.